Yes, sir, we indeed see you.
Okay, great. That sounds good.
Well, good evening, everyone. Thanks so much for participating in this Primary Care for All webinar series, which is made possible through a partnership between the National Center for Primary Care and Clinical Directors Network. I would like to personally welcome you to tonight's webinar, which is entitled Management of Oral and Maxillofacial Infections, and we will also have an added benefit of discussing some incision and drainage techniques. Our presenter tonight is Dr. Tracy Dillon, who is an oral and maxillofacial surgeon here in the Atlanta area. Dr. Dillon has been in private practice for about 12 years. He's a member of the American Association of Oral and Maxillofacial Surgeons, and he's the president-elect of the National Society of Oral and Maxillofacial Surgeons. Tonight's host is the very able Dr. Roy Brooks, who's no stranger to this audience. He's a public health dentist serving vulnerable populations in the Atlanta area for over 25 years. He currently is a dental director at Georgia Regional Psychiatric Hospital. Accreditation for this webinar has been approved for CDE credit. However, CME credit is pending with the American Academy of Family Physicians. Questions and comments can be submitted to the presenters throughout the presentation. To submit a question, please type your question in the box provided and simply click the submit button. With all of that said, let's welcome Drs. Brooks and Dillon.
Thank you, Dr. Brooks, and welcome to the audience. I'm really feel that it's an honor to present to you guys tonight and share some of this information and just share some knowledge. I felt like it was important to share some of this with you and maybe I'll try my best to answer most of the questions that you have, and just try to give you some insight and maybe a few pearls if you can from here to there from time to time, and just feel free to ask me any questions. I'm wide open. I chose this topic. I had several topics and just thoughts in my mind, and just came up with this one. I felt like this one probably would be a good one. Dr. Brooks mentioned to me that a lot of some of the attendees here tonight may practice in some areas where some of these let's say techniques or some of this treatment may have to be performed by yourself versus having to refer it out. So being that keeping that in mind, we try to present something that is going to be helpful to you. So from there, we're going to get started, and the name of the topic, as you can see, is Management of Oral and Maxillofacial Infections in Incision and Drainage Techniques. We're going to get started. So here are a few lecture objectives I came up with. We're going to try and identify the etiology of oral and facial infections. We're going to review some of the pathogenic bacteria. We're going to discuss some antibiotic coverage for some severe or advanced infections. We're going to also talk about the spread of infections in the head and neck from one space to the other, and and as it spreads and as it becomes let's say an area where it should be I&D'd, we'll talk about some I&D techniques. Okay. As we start to mention and talk about bacteria and how this actually starts to happen, as we all know, there is a mixture of anaerobes and also aerobes. Of course, aerobes are the bacteria that lives in the presence of oxygen, and of course we do have anaerobes. So as we can see, aerobes make up about 7%, and usually there's a mixed organism base, which is like 60%. Anaerobes make up 33%, and the average isolates per specimen, different kinds of bacteria, would be about 4 different I would say strands of bacteria. the gram-positive aerobic and the facultative streptococci are often seen in addition to the ones mentioned, as we just mentioned there, and which is a common pathogen and most numerous. Also, this bacteria actually produces something called hyaluronic acid. Well, this is an enzyme, hyaluronidase, which degrades to hyaluronic acid, and it's believed to play a pretty significant role in the virulence of bacteria. What kind of bacteria is it? So we call it alpha hemolytic strep. You know, the viridans group make up to 88%, and as you can see, there are numerous species of bacteria that we see: salivarius, aeruginosus, and the mitic group, which is also known as strep mitis, strep sanguis, and the strep pneumonia. The beta hemolytic group is strep pyogenes, which are mostly the pathogenic or hemolytic group, and they're most pathogenic. And they're, usually the beta hemolytic group is the cause of strep throat, rheumatic fever, scarlet fever, and also responsible for toxic shock. And I'm not sure if a lot of you are familiar with necrotizing fasciitis. We'll get into that a little later in the presentation. So just a little bit more about the bacteria. Pseudomonas, aeruginosus, there's a strep intermedius, and as you can see, only a small group of these streptococci species are resistant to the penicillins. And I'm sure that everyone is familiar with endocarditis. This is the group that's responsible for it, this mitis group. And again, we talked about the anaerobes, Provotella and Porphyromonas. Of course, these are the ones, again, that live without oxygen, and what we seem to think are the deeper space bacteria. All right, so how does this bacteria work, and how does this infection start? It's usually initiated by the aerobic bacteria, which again we talked about, just mentioned that lives in the presence of oxygen. So they gain interest to the tissue. The aerobic bacteria causes the cellulitis. It causes hypoxia and then acidosis in the tissue, which also could play a role in the difficulty in getting a person anesthetized when they have to have a dental extraction. But this becomes a favorable environment for the anaerobes. So then the anaerobes start to follow, and with the mixture of the anaerobes and the aerobes, then together they form this, what we call the symbiosis, which means that they work closely together to cause something major. And when the anaerobes actually invade the area, you have tissue destruction leading to pus. Tissue enzymes destroy the antibiotics that we briefly talked about earlier, so it pretty much makes some of the antibiotics resistant to the infection, or the bacteria resistant to the antibiotics. So how does antibiotics work? It's important to know that. Important to know what kind of antibiotic you want to prescribe, how it's going to affect the bacteria that you're dealing with. It's important to, when you're dealing with infections, and it's important to know about the bacteria, because then you can prescribe the appropriate antibiotic. For example, the penicillins that usually affect the cell wall of a bacteria. We talk about the erythromycins, chloramphenicol, the tetracyclines. Those affect protein synthesis. And the polymyxins, nystatin, and amphotericin Bs, which are the ones that we don't tend to prescribe a lot, but those are the ones that more have a detergent effect. nucleic acid metabolism just deals with the nucleic acid that's in the cell and the reproduction of the bacteria. That's the ciprofloxacin and the metronidazole. Intermediary metabolism action.
And Doc, when you say detergent effect, what is that?
You know, my understanding of detergent effect is just the amount of the antibiotic, or the strength of the antibiotic as it pertains to the bacteria that you're treating. I was going to say, and let's go back to the metronidazole. I thought about that. It's one that I prescribe quite a bit. The metronidazole, in addition to the penicillins, is usually a good combination for deep space infections. One that is not on here is one that's pretty common is the clindamycin, or the cliacin. Cliacin is definitely a bactericidal. It could be bacteriostatic at low doses, 150, 300. At 900, clindamycin is a very good bactericidal medication. That
Doctor, you saying 900 milligrams every day, every 6 hours?
No, 900 milligrams every 8 hours.
8 hours.
Yes.
For what duration?
I'd say for about 7 days.
Okay.
Yep. That gives it a stronger dose, is a bactericidal dose. All right, so anyway, moving on, the MALLAMPATI classification. I guess you're like, okay, what is this about? Well, for us, a patient comes in, it's important to assess the airway. If you're in a rural area and you're thinking about, okay, is it possibly airway compromised? You know, this is what we usually use to more or less diagnose a person's airway. And you know, and also when you talk about MALLAMPATI, you can also think about sleep apnea and so forth. But this is more geared around infections, and also, you know, possible elevation of the tongue due to infection spreading under the tongue, invading the submental space and the sublingual space, which we'll talk about. So, you know, class 1, you have visualization of the soft palate, the fauces, the uvula, anterior and posterior pillars. So in other words, you can look in a person's mouth without them saying ah, and you're able to actually see the tonsils, the uvula, the entire uvula, soft palate, and maybe some of the posterior airway. Class 2 is going to be the visualization of the soft palate, fauces, and the uvula, but you won't be able to see the entire uvula. So here is class 3. You see the visualization of the soft palate and the base of the uvula. Class 4 being the soft palate is not visible at all. So going from better to worse, if you mean. So that's what that's about. If you need further explanation, I can I'd be glad to speak more about that. So what about odontogenic infections and some of the most common spaces of the head and neck? Let's talk about some of those. So as we talk about fascial space and fascial space anatomy, we're going to mention and talk about the pterygomandibular space, the canine space, the sublingual space, the submandibular space, the submental space, the retropharyngeal space, the infratemporal space, lateral pharyngeal space, and also the buccal space. Well, some of the primary spaces are very close to some of the, let's just say, some of the other cavities other cavities surround some of these spaces or can be involved very easily just due to the spread of the infections. So as we look at this diagram here, we see that the maxillary sinus is here. Right next to the maxillary sinus, of course, is the nasal cavity. and now you can see like how close the roots approximate the sinus floor. We worry about spread of infection in the upper jaw, and it is thought that once you have infection in the upper mid-face, you know, there's a concern because usually there are no valves. It was thought that there are no valves in some of the facial veins, so you get spread of the infection in a retrograde, more or less, action, and it can get to the what we call the cavernous sinus, which is inferior to the brain and posterior to the eye, near the sphenoid sinus, and it can involve the brain, and you can have a brain abscess from a tooth from infection from a odontogenic origin. So
now,
yeah.
A, B, and C on the diagram are the
Yeah, so that's the maxillary sinus. The B is the nasal cavity. The C would be like the soft palate or the palate. I'm looking at D, looks like the sublingual space. As we look down here, we see this is the mallohyoid muscle under the tongue. Here is the buccinator muscle or the masseter muscle here. And of course here's the skin and more or less the buccal space. So
and E would be what?
E looks like it could be the inferior to the border of the mandible, so that would be the submandibular space.
Okay.
That would be below the mallohyoid. And so we see the body of the mandible, submental, canine, buccal, vestibular, submandibular, and sublingual, as we mentioned. So I added this slide because here's an important slide to me, and also this is when the infection, this is the lateral pharyngeal space, by the way. The lateral pharyngeal space is one of those spaces. It's more or less posterior to the tongue, posterior to the pterygomandibular raphe. Let's just say it is medial to the and I say medial, that means it's closer to the tongue, and it approximates like the medial portion of the ramus. What makes this space difficult and what makes this space dangerous is because once infection spreads there to the lateral pharyngeal space, you can actually see here where the airway starts to become, the airway is involved. So once the airway gets involved, thank you. Once the airway is involved, you know, not only does the patient start to complain about difficulty breathing and so forth, they also start to complain, you know, about difficulty swallowing, not able to maintain their secretions. You know, they have to more or less, they can't lie back. They have to almost have them sitting up at a 90-degree angle. But also what makes this space worse is this lateral pharyngeal space. It's right in front of the posterior airway, and what we see here is the spine. So it also communicates with the retropharyngeal space, and then the retropharyngeal space communicates with the danger space, which is the danger space being as it extends down into the chest. So you can have infection that actually goes into the chest as a result of this particular space spreading from lateral pharyngeal to retropharyngeal to the danger space. So but that's important there.
Okay, Doc, couple of questions.
Yeah.
Okay. One Doc, Amber Monique Williams, is there a mouse with a pointer that can be used? Do you have a mouse that can point out what you're talking about? Is it working there?
Okay, yeah, it's actually yes. I thought you guys were able to say it. I'm so sorry.
Okay.
So what we're saying is, Amber, thanks for Thanks for letting us know that. Here, this is the retropharyngeal, lateral pharyngeal space. Now this space is bound by on the lateral side. If we can speak lateral and mesial, there are some superior pharyngeal constrictor muscles that are, let's say, posterior to your airway, and also on the medial side, what you see right here is the lateral pterygoid muscle. So with this space right here, the way you approach this space, and we'll talk about drainage of this space, you know, I drain it from the outside. I do understand you won't do that maybe, but you know, it can be drained from inside of the mouth if need be. Here's what one of the cardinal signs of a lateral pharyngeal space involvement is. You will see deviation of the uvula. The uvula will no longer be in the midline. The uvula will be over to the opposite side, to the left. When you see that, that's definitely one of those urgent type infections that should be treated pretty seriously and urgently.
Okay, now Doc, there's also how often and how quickly does this occur? Is it only with third molars? This is from Dr. Watson.
No, it doesn't actually occur only with third molars. It can actually spread. Let's say if you had a you know, the retropharyngeal or lateral pharyngeal space, you know, it can communicate with the buccal space. These spaces, because of the fascia in the face and the neck, it can actually communicate with other spaces. So no, it just doesn't have to happen with third molars. It could be, you know, a person can have a tonsillar infection as well. You know, it can be an upper tooth. I've seen it from impacted third molars. I've seen them from bummed out or grossly carious tooth number like 13, 14. You know, as that infection starts to spread in the palate and it starts to kind of, with gravity, kind of go through the fascial planes, you know, it can actually, you know, once it gets to that space and the bacteria starts to reproduce, it happens pretty quickly.
Okay, now, other question. You said this communicates with the superior masseter, correct?
I said with the masseter? Yeah. I said with the masticator space.
Okay, now, when you're talking here and we're in this by ourselves, somebody comes in at 4 o'clock Tuesday evening. I look in there, see everything what you're saying. What do I do? Do I try and incise and drain that, or get them a shot of penicillin, rush them to the hospital? Because you're saying this progresses very quickly, and you're saying quickly in a matter of days, or a matter of weeks, or a matter of 12 hours. I'm more saying in a matter of hours. Okay.
Yeah.
So what should I do?
Well, I think the first thing that I would do is, are we all pretty comfortable with aspiration? Meaning that if you have a 10 cc syringe and you have an 18 gauge needle, what's going to be in that space also, as you can see over here, I'm just going to try to take this pointer and go a little bit further back. This is the external carotid, internal carotid, and probably the retropharyngeal vein, or looks like it's another vessel there. I'm saying if you were to do something that's, I think that would help the patient, is you could consider aspirating, meaning that 10 cc syringe in a on an 18 gauge needle. Don't bury the needle. The needle is probably about 1.5 inches. Go superficially and see if you can establish some drainage. So anyway, I would say in addition to that, you can always make an incision in the retromolar area, retromolar area. Let's say in the area of that third molar. I wouldn't go too far toward the tongue. We worry about the lingual nerve, but if you stay on bone and then you dissect on the inner side, I'm sorry for using my hands, and I thought, but anyway, if you dissect on the inner side of this bone, there's going to be a pocket there, and that pocket is going to be full of pus. I can probably assure you, if you see that uvula deviated and that person can't get to a hospital or get to someone, that's going to be probably the best treatment. What you're trying to do is you're trying to limit the bacterial load. Limiting the bacterial load means do an IND, something to drain some of the major infection, so you won't, so the antibiotics can work. And also, it's very tough for antibiotics to penetrate an area like this. So you're trying to definitely drain that space. How do I drain the space? I'll show you a little later how I would drain this space. And we're talking putting Penrose drains in. We'll talk about Penrose drains here shortly.
Okay, now Doc, with the antibiotics.
Yes.
If you have a patient like this and maybe it's not to the point of draining, you go up there, can't get anything out, do you put them on the 900 milligrams of clindamycin?
I definitely put them on the 900 milligrams of Clinda.
Okay, antibiotics can affect that GI. Are you going to get any distress with that 900 milligrams GI distress?
Yeah, you may get some with the 900. I'd start them on a loading dose and probably go 600 PO. If they're in a hospital setting, I'd definitely start an IV and give them 900. I'm not sure who's comfortable starting IVs, and if you guys do that, but if you're in a hospital setting, you're going to have them on 900 around the clock. However, orally, I've given 900 milligrams PO and as a loading dose, and then keep them on 600 milligrams every 6 hours. I've done that. I've also given penicillin 500 milligrams and Flagyl 500 milligrams. Penicillin, you'll take one every 4 hours, and Flagyl will take one every 8 hours. That's real good for the anaerobes. Again, it's good for the anaerobic bacteria. But what we're saying is, I think your question was about, you said a drain, placing a drain in. Yeah. If you could place a drain, let's just say, the important thing is, because this bacteria is, bacteria and the weight and gravity, you're going to actually have bacteria that actually is going to spread now from that lateral pharyngeal space to that submandibular space and the retropharyngeal space, sublingual space. So it's going to be spreading pretty quickly. You really need to get a CT scan of the patient, you got to do a CT scan with contrast. But I was going to say also, and I know what I was just thinking, you said, is there going to be any GI upset from the Clinda? It may be a little GI upset from the Clinda. What we want to rule out after a dose and after we get the infection under control, we want to rule out pseudomembranous colitis, which is colitis that that's bacteria related, because you've killed all the bacteria in the gut, and the gut now cannot handle it. So then, treatment for that is metronidazole. So you give them a dose of metronidazole, maybe a week's dose, and it'll clear that up.
Now, person comes in with this.
Yep.
I somehow establish either drainage or place a drain in there. I put them on the clindamycin.
Yep.
And I send them home.
Yes.
Okay. Now, should I expect this to kind of be resolved in a week or 4 days, or when do I bring them back to check to see how we're doing?
All right.
Because this is a threatening situation.
Yeah, it could definitely be a possibly airway embarrassment situation, meaning that the airway is beginning to be compromised just looking at this, because we can kind of see how this has already kind of started to kind of change. I think what's important is to be able to recognize, when something could be threatening. And my position tonight is to let you know, when you start to see the deviation of the uvula, and when you start to have a person that can't really swallow, they come in with a cup because they're spitting a lot, those are the ones that require some urgent attention by someone. And if you can't refer the patient out, if you want in one of those areas where you can't, then you have to do something for this patient.
Okay. Now, you feel this is in the scope of the general dentist to get this started? What you said to do when you see this? Is that in the scope?
I think it's in. Well, yes, I think it's in the scope to at least aspirate. You may not feel comfortable because of the anatomy in that area. No major vessels, particularly. What we've learned in our training is, as long as you stay on bone, and just try to stay there, it's usually a safe place to be, versus going into an open space. But that was my reasoning for saying aspirate. If you go in and you aspirate blood, chances are, you're not really in a right place. You've done something else, but you haven't caused a major issue because you've only aspirated with the small bore, or some would say it's a large bore needle, but 18 gauge needle. With pressure, you can the bleeding will stop, but chances are you're not going to invade a blood vessel there, and you'll be able to get into it. In fact, what you will see, you'll actually see more like a pocket where the pus is there, just waiting to kind of be more or less released. So you won't go very deep at all. You just go right into the mucosa, and so I do think that's within the scope of someone who definitely, if you have done other INDs, that's an area where if you cannot refer and if you need to do something right away, that's what you have to do.
And how long, again, the question is, how long do you wait to see if the antibiotic is working after you do this?
Well,
are you talking a couple of days, or? Well,
we're going to get into this, and when we talk about like how often you should see a person back after infection, after you IND them, but for a person that I would see the person back the next day.
Okay.
We're always concerned about more swelling as a result of something that we do. Aspiration, you shouldn't expect any swelling. But if you go in, like we're going to talk about, and we're going to open up and show some techniques of INDing, with hemostats, then you expect more swelling. But if you've gotten some good, let's say, a path of drainage for the infection, then I think that swelling is nothing you should worry about. My only concern is swelling when it comes to the airway.
Okay.
So.
And another question is, I guess they're asking, is pseudomembranous colitis, is that possible without another antibiotic agent or something?
I'm not sure if I understand your question. Can you develop pseudomembranous colitis?
Right.
Some people will have colitis, period, like patients with maybe ulcerative colitis, or let's say Crohn's disease, or whatever it may be. But I'm saying that if it's antibiotic related, then we know how to treat that.
Okay.
You know what I'm saying? So
and another one, Doc, before we move on, and doing pretty good here. Many of my patients are substance abusers.
Right.
Okay.
Okay.
Now the metronidazole. Yeah.
Mm-hmm.
Is that relating to alcoholic effect due to the population? What is that? My concern with that and the drug users and alcoholics that I may be seeing.
Only if they're allergic to it. Metronidazole is what we call Flagyl.
Okay.
And Flagyl, and from my understanding and with my knowledge, I don't think we should have a problem with, with any alcohol, though, taking antibiotics. It's going to limit the ability of it to work. So I'm not sure if you're asking me if the antibiotic a person is drinking and then they take the metronidazole, but we're saying that for a person that develops this, treat them with that metronidazole, 500 milligrams 3 times a day for about 5 days, and it should clear up. If the diarrhea continues, a loose stool, we call watery stool, then they should probably be referred out to their physician.
Okay.
Yeah.
But alcohol doesn't work with anything.
Correct. Correct.
Okay. And what potential for Mars infection? Do you need to culture this, or how do you determine?
Well,
You know, if somebody comes in, you do this, and a week later it's still there. How do we know we have the right antibiotic, or what do we do?
well, that's what we need to do. We're going to talk about culture and sensitivity. I mean, culture and sensitivity. What we learned is any infection, if you have the ability to send this to a lab, any infection that you drain should have a culture and sensitivity done, or culture done. You can do, for me, what I do is do the anaerobic culture, and I do an aerobic culture. Anaerobic culture is placed in a bottle that you can screw the top on. The aerobic culture is like, you've probably seen it. It's on a cotton applicator, and you basically just smear the bacteria, get some of the pus that comes out, send it for culture and sensitivity, and a lot of times they'll have a preliminary report back for you and tell you what the antibiotic is sensitive to. And usually you have to indicate, is the person on antibiotics now? Are they not? You know, and then they will say this bacteria is sensitive to this. This is resistant to this. You know, so they'll lead you in the right direction. I saw something about MRSA. MRSA is methicillin-resistant Staph aureus. I would think Staph aureus and methicillin-resistant Staph is more on the skin. So when you start talking about the nasal cavity or more of skin infections, that's more MRSA related. I don't know of any cases that are MRSA related to intraoral infections and pus or cellulitis areas. So, all right. So let's talk about this masticator space infection. Some would think that when you talk about the masticator space, it talks about the masseter muscle. But the masticator space is the space that involves the muscles of mastication. In other words, masticating, so you're unable to open your mouth. So we call that, the medical term is trismus. A person comes in with trismus. That means the infection has invaded this space where the lateral pterygoids are, you know, the medial pterygoid. It's probably invaded the buccinator muscle. All of these spaces are now involved. So now the muscles, because of the bacteria that's invaded the muscle, the muscles can't contract. So then you won't have any opening. Okay, so anyway, let's talk about the masticator space, and we're going to speed it up just a little bit. We got quite a few more slides to go through. Masticator space includes all the muscles of mastication, as I mentioned, ramus of the mandible, and zygomatic arch. So we all know the zygomatic arch is, I'm trying to find that pointer again, but I don't have it. Well, the zygomatic arch is lateral to the right and left orbit. It actually gives your face the projection. The zygoma is right. There we go. Zygoma is here. Zygomatic arch is here. So anything below the zygomatic arch, all of this buccal space, masticator space. So commonly associated with the mandibular third molar. I've seen some that it doesn't have to be. So anyway, clinical characteristics, as we said, trismus, pain, and swelling in the area of the body of the mandible. Okay, so here's a masticator space that have gone into the submandibular space. So what do we have here? Firm submandibular swelling, pain, tenderness to palpation, limited trismus compared to the masseteric space. Well, there is a space called the masseteric space and the submasseteric space, but for the sake of this discussion, let's continue, and I'll be glad to explain that. But IND of the submental and submandibular space should be done from an extraoral approach. So we all know if you try to do something from the intraoral approach, because of gravity, as we talked about, it won't work. Where would I drain, or where would I incise the tissue? Is it anything in this tissue or in this area that I have to worry about? Well, if something further back, there's a facial artery and vein which is slightly anterior to the angle of the mandible. But here at this area, I'd make a small incision. We'll show you how to do that in just a second. But we'd make a small incision right there where it looks like the abscess is about to. It usually has what we call a head on it, so you can actually make an incision right there. You won't do anything detrimental to the patient, and you will be able to establish some drainage. Let's see. We can address that intraorally. I would address it intraorally and extraorally, but for I guess for the audience, it can be done intraorally. Yep, submandibular space. We will put a drain in. Drain is going to stay in there for about 3 days. We're going to cover them. Now, back to that MRSA. Now, here's an area here where we're concerned about staph. Staph is on the skin. Staph is really, can't say never. Staph is very, very unlikely you'll find staph inside of the mouth that's involved in an infection, but it could be a mixed organism in the infection. But what you're going to do for this person, you're going to prep them extraorally. I usually always prep them with betadine if they're not allergic, and prep them in a ring fashion, trying not to go back where you've already prepped to keep everything sterile, and using a 15 blade, it's just inside the tissue. We'll show you that.
And if they're allergic to betadine?
I would use something like some, there's another, in the hospital we use chlorhexidine.
No alcohol.
No alcohol, right. Yeah, well, you can actually use alcohol. I would use alcohol. I would use alcohol, but it was surprising to see, like in the hospital, we use patient allergic to betadine. We use this chlorhexidine-based cleanser for the face. So what about the buccal space? The buccal space lies between the buccinator muscle and the superficial fascia. Clinically, the cheek is swollen, no trismus, and patient has fewer symptoms. So a person can have a buccal space infection, but still they're able to open their mouth, and that's before the buccal space. That's before it starts to spread. So IND, you have opening at the inferior margin, of the buccal space facilitates dependent drainage. So what we're trying to say earlier was dependent drainage means gravity is going to aid you in the draining of these spaces if you go inferior to where the actual pus is. Or the pus pocket. Let's talk about incision and drainage of spaces. So let's talk about some places or some sites of incision and drainage. The masticator space, inferior border of the mandible. Temporal space, above the zygomatic arch, both superficial and deep spaces. You probably won't do that one, but something you would see if the temporal space is involved. It's like the patient will have some swelling in the temporal area, and you'll be able to see that extraorally. You can try to approach, if the infection has moved to the temporal space, chances are you can drain them inside of the mouth as well. And so submandibular space, lateral pharyngeal space, intraorally along the pterygomandibular raphe. Pterygomandibular raphe, as we talked about, is the area distal to like a third molar, number 17 or number 32, going up the ramus of the mandible. Lateral to the ramus of the mandible is the lateral pharyngeal space. Buccal space, again, intraorally in the mandibular mucobuccal fold. You can't go wrong down in the vestibule. Anterior to, let's say, the posterior mandible. We worry about the facial artery and vein. The pterygo, I guess the mandibular space looks like, and the infratemporal space. So what about incision drainage? Let's talk about this. Infections that spread beyond the teeth into the oral vestibule are usually managed by incision and drainage. So something usually has to be done when it spreads beyond the teeth into the vestibule. Usually you can palpate an area. It would be fluctuants, so forth. infection will then erode through the thinnest bone and cause infection in the adjacent tissues. So, principles of IND: maintain a sterile fill, local anesthesia, aspirate. You know, we talked about aspirating with that 10 gauge. It says a 10 gauge. You know, I would use an 18, but and also a 10 cc syringe. Straight hemostat. We'll show all those here shortly. More principles are: extend the dissection to the roots of the teeth, causing the infection. So in other words, when you dissect through the tissue, go through the tissue with your hemostat. I want you to be able to palpate the inferior border of the mandible, and then looking, let's say if you put your left hand in the mouth and you're actually working with your right hand, be able to feel the hemostat. Do not pierce the tissue inside of the mouth. You can kind of feel yourself in the mucosa, under the mucosa, but make sure you go right there to the area where the tooth is, in question is. And my motto is, I don't usually let, I usually always will try and remove the tooth, remove the source of infection. That way I know the patient is going to get better. Okay, stabilize the drain with sutures. We're going to talk about what suture to use. And do you leave drains in for a long period of time? We'll talk about that. So, principles. Patients placed on an antibiotic. If drains are placed, patients to follow up daily for irrigation. I'd watch these patients closely, and patient to follow up within a week. So if a drain is placed, like he mentioned, I'd probably see the person every day, and I'd even manipulate the tissue with the drain in place. I would use a Penrose drain. There's a 1/4 inch and a 1/2 inch. There's a 1/2 inch and there's a 3/4 inch, and that it comes in. Usually comes in about somewhere about 12 inches long. You don't need all that. You can cut it, and I would place it, secure it with sutures. Always, an aside is always use nylon sutures on the skin when you're securing the drain.
Doc,
Yo.
question.
Yep.
How much, you're saying you cut this drain. You need a 4-inch piece, a 3-inch, or you said don't use 12?
Well, don't use. I'm just saying you're gonna take the 12-inch drain, and you're gonna actually grab it with the hemostats, and you're gonna go into this pocket that you've created.
Right.
There's gonna be some extending beyond your incision site. You're gonna cut that excess off.
Okay. How much are you trying to put in the pockets? You fill that pocket till it's full?
Yeah, I would put the tip. I would try to put that tip to the base of the pocket.
Okay.
That's what I would do.
And then once it's at the base, are you still pushing in, or
No.
it's a strand from the base
Right.
out?
Now, you're going to do it. You're going to do 2 ways. One is you're going to have one hemostat. One hemostat is going to go in and push it into the actual socket, into the pus pocket.
Okay.
You're going to know that because you're going to have drainage coming out.
Okay.
You're going to leave that one in. If you can, have your assistant hold that one in place, and then you're going to suture the other end to the skin.
You go through, your needle goes actually
Through the skin, through the drain, secure it.
One loop, twice loop?
You could do it twice. I'd secure it in 2 places.
Okay.
Then you're going to gently release your drain and slowly back your hemostat out.
Closed.
Closed. If you see the tip of your drain, you got to place it back in.
Okay.
Sometimes what you can do is take that same syringe with that needle now, and you can go through your drain, and you can actually palpate yourself irrigating with what we use as normal saline, and just copious amounts of normal saline, what you want to use.
Okay.
And for this patient, you put the drain in, you send them back a couple days. My typical thing is what I do, I usually leave the drain in for about 3 days. If the person is still really, really draining a lot, chances are the antibiotic may need to be changed. You know, you have to really review that to see why are they still draining a lot, and just continue to irrigate them daily.
And once that mass goes down, you take the drain
Yeah,
out.
I would take the drain out after about 3 days. Once the actual drainage is actually stopped, it's probably going to get a little crusty. Just cut the sutures, pull the sutures out, pull the drain out. All right. So look at this inside. I know this is one that all of us can do. swelling right there, and in that buccal plate area, buccal cortical plate. But you see how this person has drained this in an inferior dependent site. So if you drain it up here, you're still going to have a pocket, you know. So dependent drainage, okay, that's the key. Here's a person that the infection now has gone to the submental space. I know you guys are probably familiar with Ludwig's angina. This is not quite Ludwig, because Ludwig's involve the submental, submandibular, sublingual spaces, all of them. But this is a submental space. Laterally, the space between the anterior belly of the digastric muscles. Inferiorly, the skin and fascia, which is here. That's the skin and the fascia. And superiorly is the mallohyoid, which is a muscle right under the tongue. And of course, you know, the mandible. So what do we drain? So this outline, you can look at this at your leisure, but you will get to see all the muscles. You'll see the space. You'll see everything there that's involved. And you'll see where the inferior alveolar nerve injection, the hallmark, trismus, you know. So, but here's what I was talking about too, and I'm kind of rushing now because we're kind of running out of time. The retropharyngeal space, how it connects with the danger space. This will go into the chest. You can actually take a CT scan of the chest and you will see pus. You will actually see bacteria that has formed gas in the patient's chest. That will definitely require treatment by a cardiothoracic surgeon to open the chest and drain the chest, drain this bacteria. Here's another one, buccal space. Remember, dependent drainage, swelling below the zygomatic arch. This is typical of a buccal space. Here's the armamentarium. I don't have to read this. We're going to go on. 18 gauge needle, Penrose drain, sutures, silk suture. If you're doing it inside the mouth, I don't put silk sutures on the skin, so I always use nylon on the skin again. So here's the gentleman right here. He has a drainage. Obviously, looks like from this is a canine space. It's you know, in the area of the canine and below the infraorbital rim. Here are some of the signs of infection. We had some questions earlier about the signs of infection. These cardinal signs, you know. So we see this, and looks like he started draining by himself. But look at this. This is what we talked about. We cleaning with the betadine in like a ring fashion. Let's see if I can get this pointer here. In a ring fashion, in a circle. After we've done that, we inject in that area so we won't bring any bacteria from outside in. And then we aspirate with this syringe. This looks like a 3 cc syringe, but I would use nothing less than a 10 cc syringe. And if you use a small needle, you won't get anything back. So that's why we're saying an 18 gauge needle I would use. If you have a 20, you can try that. It's better for me in my hands with an 18 gauge needle. Here's this action that we talked about with the hemostats. Take the hemostat, go in with the beaks closed. Palpate the inferior border of the mandible, stay on bone. There's no structure right here really that we really are that concerned about. The external jugular vein is there, but very unlikely that you get that. It's in an area where there's no major vessels. And you go in, palpate the mandible. If it's a sublingual space, kind of walk the hemostats to the lingual of the mandible. Don't pierce the floor of the mouth. Open up the what you see here is the hemostats now being opened. Then come out. You should get a lot of pus comes out as you take out the hemostat, or it may come out without you taking it out. Here's that Penrose drain we talked about, putting that Penrose drain in, and this Penrose drain is now being sutured to the skin. Yep.
Here with the hemostat.
Yep.
You go in closed.
Yep.
You go to the mandible. Now, when you say you open and you close, are you walking that in that space? Or you open, close one time and come out? Or you move it around?
I usually move it around. If it, yes, I'd put my finger in the floor of the mouth if I'm going to the lingual, right, and I would feel myself opening that syringe. I mean that hemostat in that space.
And you're not trying to actually grab any tissue and bring it out.
You don't want to grab any tissue.
What is the action of opening and closing? What are we doing there?
Well, sometimes you can have what we call loculations. Loculations is when tissue has bound to each other. You're trying to create an area of, create this space and a path of drainage. That's more important. So when, let's say if you have bacteria that hasn't formed pus yet, you don't have any pus. Now when the bacteria matures to its pus stage, it'll have a way and a place to drain.
Okay. So then but you're not grabbing anything, and you open and close, You're not close up. Make sure you haven't grabbed anything and come out.
Right. Don't grab anything. Keep the hemostats open coming out.
Open coming out.
Open coming out. Going in, closed.
All right. Open coming out. Okay.
Yeah. Okay. Canine space. You can read this. Swelling around the eye. You know, we talked about cavernous sinus thrombosis. This is when you start getting some periorbital swelling. That's important. There's a lot of different signs. We don't have time to talk about them tonight. There's an orbital apex syndrome. There is a cavernous sinus thrombosis from infection. You know, that when you have this, one of the cardinal signs, one, you may have some loss in vision. Two is the person will not be able to move their eye. They will have paralysis of one of the muscles. That way you know, this is when you know that the infection has invaded the muscles that involve movement of the eye.
Now, when you get to that point, is that beyond the general dentist? Should they be...
The general dentist should be able to recognize this, be able to make the referral right away to the emergency room for IV,
okay.
for IV antibiotics.
Okay, this is straight to the...
Straight to the ER.
Okay.
All right, so again, submandibular space. We talked about this one here. You see that big pus pocket that's actually right here. Dependent drainage. I can't stress that enough. Just dependent drainage. Let's go to the next slide. Let's see. Here's some useful definitions too. Sepsis, septic shock. Here are some situations where you begin to see if anyone draws blood and look at their white blood cell count, so forth, so on. This is when you start to see bacteria that invades the actual blood, and it's going to affect all your systems. You're going to have septic shock is when you start to have vasodilation, renal failure, ARDS, DIC, disseminated intravascular coagulation, and also this escapes me right here, but at any rate, the host response releases endogenous mediators, tumor necrosis factors. That's probably beyond the scope of this presentation, but this is all some of the factors that's released as a result of the bacteria.
And Doc, I think we're out of our time, but we thank you very much. This was very, very informative. I've worked beside you for months. Hey, I know I quizzed you, but this was really good.
Yeah, appreciate it.
And I see you neglected to put an email and phone number, but he is in Atlanta, Georgia.
Okay.
For those who want to contact him and have any further questions or consult.
Yeah, my email address is drdillon@midAtlantaOMS.com. Again, Dr. Dillon, no period, DRDILLON, at midAtlantaOMS.com. You guys feel free to email me. Be glad to help you out with whatever I can help you out with. It's been a pleasure. I'd like to thank the Morehouse School of Medicine for inviting me and giving me the opportunity to present to you guys.
Very good.
Yeah.
We do have a few moments that we can entertain questions.
Okay.
So it looks like you have one or two.
Good.
Okay, good. Okay, how do you handle when you go into drain what seems to facilitate and you get cellulitis?
Yeah, it seems to be. It seems to be fluctuant. Looks like he said. It seems to be fluctuant, and you get. Oh, geez, I didn't see his question anymore. But okay, so if you have fluctuance, then chances are, if you don't have pus yet, it's okay because you've still done a great thing. You've established one. You've broken up the anaerobes, because the anaerobes are what's creating this swelling in the tissue. So you've actually established some type of drainage where you actually you're still doing a service. So you're still actually doing a great service to that person. And but don't worry, because it's still going to get to the cellulitis stage, and then you'll have a path of drainage.
Okay, and then the next one, acute respiratory distress syndrome.
Oh yeah, that's ARDS. That's ARDS. So I just couldn't think about that, but that's what that meant. So thanks for that. I had a little mental block there for a second, but thanks for putting that up there.
Okay, and there again, great presentation. Are these slides available? And I guess Ms. Jackson will have to explain how you
get the slide. Yeah.
Okay.
Yeah. Are we angling the hemostat toward the inferior border to be safe? You're definitely going inside of the tissue, and you're actually trying to palpate bone. If you're trying to go into the buccal space, you're going to be buccal to the mandible. If you're trying to go in the lingual space, you're going to be on the lingual side of the mandible. Again, hemostats are closed. As you walk around that mandible or on the inferior border on the lingual side into that lingual space, you know you're there. You'll palpate it with the tip of your left hand as you're going in with your right hand if you're right-handed, and what you should get at that time, you should get pus that's going to start draining from where you're holding your hemostat extraorally.
And Doc, I have a question here. You mentioned antibiotics and the different ones.
Yeah.
Is it one that works better in a certain space, or the one works generally good everywhere, or?
Well, you know what?
If you have a certain infection, certain place, do you need this antibiotic or what?
Well, I think that because we've all probably taken penicillin multiple times throughout our lives, there are going to be some bacteria that's going to be resistant to it. So I usually don't use penicillin first. I usually always go to clindamycin. Clindamycin has good anaerobic and aerobic coverage. At a high dose, it's going to be, like we said, bactericidal. So I think to start with, if it's anything that's beyond like a buccal abscess, clindamycin works well for me.
Okay.
And if it gets to be a thing like, oh, I can't afford it, oh, it costs so much, blah, 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 then you have to go to the antibiotic penicillin and Flagyl. I give like 1,000 milligrams a loading dose, and I'll give 500 milligrams of Flagyl, and see how that works.
And how long do they stay on the penicillin Flagyl?
7 to 10 days, surely.
And the penicillin is every 6 hours?
Every 6 hours.
Flagyl is every 8?
Every 8 hours.
Okay, and that's 10 to 6 days?
Yeah, that's 7 to 10 days.
Okay, now with the clindamycin, well, how much are you getting? You said a loading dose of a...
I do a loading dose of either 600 or 900,
okay.
And then I keep them on clindamycin Q6, 600 milligrams Q6.
For how many days?
At least a week.
A week, okay.
Yes.
Okay. And for pain?
For pain, it just depends on what their tolerance is. I mean, I usually always tend to give some ibuprofen. I'm going to give some, I usually lean toward Percocet, because Percocet is really good on the stomach. These patients are not probably taking in enough PO fluids or liquids, so they're going to have an upset stomach from the Lortabs and the Vicodins. So I tend to use Percocet, 5/325, 7.5.
Okay. Now, does the Flagyl work with clindamycin or only with penicillin? Or you don't need it?
You really don't need it, because that's a little overkill.
Okay.
Yeah. So, I mean, but look at what your culture and sensitivity, how it comes back, because it may say sensitive to metronidazole, or something, so I would base it on that from that culture and sensitivity standpoint as well.
Now, with your drain, you mentioned they come in different widths. That depends on the size of the abscess? Which one? If you're ordering, do you order both, or you just need one?
You know what? If you order that 3/4 inch Penrose drain, it's going to be on the bigger side. I think, based on, I usually make a larger incision. I think there's a 3/4 inch, then there's a 1/4 inch. I would do the smaller size. For people, for ones who are not experienced in doing it, because you're not going to make a large incision. It's going to be a small incision site. The smaller drain will go in without folding on itself and so forth. I would do that.
Easier to handle.
A little bit easier to handle.
Okay.
Yeah. You know, if you don't have any Penrose drains, we talked about earlier, Dr. Brooks and I talked about, you can always get a sterile glove. All you're trying to do, not only the drain is there, the drain is there to maintain patency during this drainage process. If you don't place a drain, you go in and you establish drainage, the tissue is going to heal and not allow the bacteria to drain. So the whole purpose is to put something there that's going to maintain a path, so this pus you can decrease the bacterial load for this person.
Okay, now Doc, one thing you didn't mention, I know, I've done it. When you open that abscess up and you're in there, do you stick the surgical drain in there and suction out as much as you can, or you don't do that?
Intraorally, you can.
Well, okay, intraorally. What about extraorally?
Well, you know, we try not to go from inside the mouth outside. You know, we don't like cross contamination.
No, I mean, if it's...
Yeah. Now we can go from usually what the thing is, you can go from outside in. Usually don't go from inside out.
Okay. That's it. Okay.
Yeah.
Thank you now.
Okay.
Thanks everybody for joining us this evening, and looking forward to having this experience with you at another time.
Thank you so much, everybody, for joining in.
I would agree, and thank you, Dr. Dillon, for an insightful presentation, and for Dr. Brooks for moderating the conversation tonight. It's been recorded, and it will be stored in our on-demand section for your review. Also, for those of you who are requesting the slides, and you can feel free to email me, sajackson@msm.edu, or email Dr. Dillon directly for a copy of those. I'd like to I'd be remiss if I didn't give a special thanks to our tech support tonight, Mr. Quallen here. Thanks a million. Want to point out just a few upcoming events to our audience. You're invited to attend next week, Tuesday, February 14th. Behavioral health clinicians will be presenting Post-Traumatic Stress Disorder, Part 2. And then on Wednesday, February 15th, Dr. Brett Kessler, who you guys may remember as the dental meth expert that we had on last month, he'll be back on Wednesday presenting a webinar entitled Concepts in Leadership. He's a leadership expert for clinicians, so it's going to be a very, very good presentation. So please join us next week, Tuesday and Wednesday at 8:30. Again, this series is made possible through a partnership which allows us here at PrimaryCareForAll.org to serve as a resource for you, the clinicians of the National Health Service Corps. Direct financial support was made possible through a cooperative agreement with the U.S. Department of Health and Human Services. An evaluation for this webinar will pop up in another window if you're using IE, or another tab if you're on Firefox. Please complete it in its entirety for your 1-hour CDE and CE credit. Thanks again to our presenters and to our guests, and have a great evening.